Good morning, good afternoon, good evening, everyone. Welcome to another twin and multiple pregnancy webinar. My name is Asma Khalil and I'm a professor of fetal medicine. I work in the United Kingdom and I'm joined by a team of experts and also Stephanie Ernest, who is not new to this webinar. You obviously met her before. Today, well, for the webinar today, I'm delighted to say that we have nearly 4,100 people registered for the webinar. So I would like to welcome everyone, and it's fantastic to see people from all over the world joining the webinar today. The webinar today will focus on sort of three areas. So the ISOUG, the twin guideline update that we published at the beginning of this year. Also, if Professor Lung, he had some technical issues, but if he's able to manage to share the screen, we would be able to also cover something about the latest evidence by NIBT. And we have Professor Conrado Coutinho, who is also going to share with us very interesting cases. And then Stephanie Ernest, of course. So I'm going to introduce them formally in a second, but just some housekeeping. Obviously, these webinars are recorded. So hopefully we started the recording. Yes, we have. And the recording is available free on the Shofik Health Foundation website. This is a charity. So if you can actually register free, and then you'll be able to access this webinars, and also as long as the webinars from the previous, the recording of the previous webinars. I'd like to thank the sponsor. The sponsor of the webinar today is Samsung, and you saw the video, so thank you for their support for the educational activities. And of course, thanking all the team behind the scene who make sure that these webinars are organized and run efficiently. For the feedback, we will have a QR code for the feedback at the end of the webinars. Please fill it. We would love to hear from you if you have any suggestions for future webinars. And we tend to mute all the participants except the speakers, as well as so that obviously avoid any background noise. But as I mentioned, these webinars are recorded. So if you turn on your camera, obviously that's sort of identity. So it's just letting you know at the beginning of the webinar. So without further delay, I'd like to introduce the speakers of the webinar today. As I mentioned, Professor Tak Yong Lung from Hong Kong, from China. He's a professor of obstetrics and gynecology at the Chinese University of Hong Kong. He's the head of the fetal medicine team and assistant dean of the medical faculty. We have Professor Conrado Coutinho, who is also professor of obstetrics and gynecology in the University of São Paulo in Brazil. And we have Stephanie Ernest, who is the founder of the TAPS Support Foundation, and she's a speaker and advocate for the care of monochorionic twin pregnancies. So thank you very much. I'm extremely grateful for you joining us on the webinar today. In terms of interactions, please we use the chat function. So let us know if you have any questions or comments. We'd love to hear from you. Certainly, one of the favorite part of the webinar is a discussion. So please engage and discuss with Sangs and discuss and put things in the chat so that we can hear from you. Okay, so I'm going to start with the first talk. So I'm just going to share my screen, and I'm going to give you a really quick overview of the latest ISOUG twin guideline that was updated and was published beginning of this year. And it's obviously a huge guideline because you can see the list of the scope, so the areas that were covered in the guideline, and it covers both the routine screening and monitoring in twin pregnancies, and then also the role of ultrasound in diagnosing, monitoring, and managing complicated twin pregnancies. Let's start with basics. So how you actually date the pregnancy or determine the gestational age in twins. So of course you have two babies. In singleton, we use the crown rump lengths in the first trimester to date the pregnancy. That's the practice in the UK and as well as in many other countries. For twins, you have two babies, so use a larger twin. And ideally, the crown rump length less than 84 millimeters, so that corresponds to 13 weeks plus 6 days. And certainly, yes, there are some studies that suggested that maybe using the smaller, using the mean, but certainly in the guideline, we recommended that we stick with what we always recommended, which is a larger crown rump lens. And the same applies if the scan in the second trimester. So if you suppose you didn't have scan in the first trimester, Conrado tells me that in Brazil, not all patients have come that early. So if you scan them for the first time in second trimester, use the larger crown head circumference. That's in spontaneously conceived twin pregnancies. What about if the IVF or assisted conception? In this case, obviously, you already have, you can do the calculation from the age of the embryo and the date of transfer. What about the monitoring? You'll be very familiar with this figures, which is outlines that in diachronic, a twin pregnancy, the first scan between 11 and 14 weeks. It's not unusual that a lot of twins would have had scans earlier than that, particularly if they had an IVF pregnancy. But if not, so 11 to 14 weeks where you do the dating, the labeling, the chronicity, most important thing, and then you offer screening for chromosomal abnormalities depending on where you work. And then after that, the next scan is a 20-week anomaly scan, the biometry, the anatomy, assess amniotic fluid, and measure cervical length. And we do have specific recommendation about cervical length assessment in twins. And then after that, every 4 weeks, and then every 4 weeks, you measure both babies, you assess amniotic fluid, you calculate the estimated fetal weight discordance, very important. And then in ISOUG guideline, we did actually recommend that we do the Doppler, the umbilical Doppler. I know it's controversial, but that's what we recommend. And then we deliver them at 37 weeks. In monocorial twin pregnancy, the first trimester is the same, so dating, labeling, chronicity, assess or offer screening. And then after that, from 16 weeks, every 2 weeks until the end of the pregnancy, because you're monitoring for monochronicity related complication, particularly TTTS, particularly selective fetal restriction, and TAPS. So we did recommend that you measure biometry, calculate the discordance, you measure the deepest vertical pocket because you're looking for the TTTS. And then we did recommend that we also do the Doppler, and just to point out the MCA, big systolic velocity, looking for the TAPS or twin anemia polycythemia sequence from 20 weeks. Certainly, I think most centers would do from earlier, from 16 weeks, like my center, for example, because it's true that there are some cases of TAPS. I've seen cases of TAPS as early as 16, 17 weeks. So the monochronicity or related complication is a discordance in amniotic fluid volumes as twin-to-twin transfusion syndrome, or discordance in the size as a selective fetal ghost restriction, or discordance in the MCA Doppler or the TAPS, or in extreme cases when you have the TRAP or twin reversed arterial perfusion. Of course, the diagnosis of the label when it fulfills the diagnostic criteria, but it is true that more often you will have a degree of discordance, but it's not severe enough to reach the diagnostic criteria. So it's important that you know the diagnostic criteria, number one, and important to know what to do when you have discordance, but it doesn't leave this diagnostic criteria. So how often should I monitor these pregnancies? And is there any markers to tell us how to triage these patients? So this is what I showed you earlier, the flow chart for monitoring the monocorial twin pregnancies. This is ultrasound views of what you need to obtain in terms of the biometry. You see here the T sign, the intertwin membrane, showing that it's floating, so there's no TTTS, measuring the deepest vertical pocket, and the Doppler assessment. So let's start with screening for chromosomal abnormalities, and I'm just going to share with you the latest recommendation we included in the updated version of the twin guideline. Is the fact that it is true now that the data is clear that the cell-free DNA is the most accurate form of screening for common chromosomal abnormalities, particularly Down syndrome, offered from 10 weeks. And for trisomy 18 and 13, also appears promising, but the data is limited because of the numbers. So what about if you work in a healthcare system where NIPT or cell-free DNA is not available? In this case, the recommendation is to screen using the combined test. And certainly there are some countries or healthcare system where they don't do the biochemistry component of the combined test. They can't do the PAP-A and PTCG and correction for twins. In this case, you use a combination of maternal age and the nuchal translucency. And yes, the performance will be slightly lower, but not massively lower. What about if you have vanishing twin or vanished twin? In this case, just nuchal translucency with a maternal age, particularly if you have a fetal ball in the other sac. And certainly there has been some studies where suggest that maybe the BAP-A is the one that's maybe the levels that might not be accurate. So you can do the maternal age, the nuchal, and the beta ISOUG. There was some suggestion study about correcting the level of the BAP-A for the age of demise of the vanished twin. But the problem that you don't know when the baby died. You do the scan and you see that's already vanished twin. So you just taking the size is not very precise. So, and therefore I think it's maybe an interesting concept, but it needs to be validated and replicated in other studies before its recommendation or routine implementation. The self-free DNA or the NIPT in twins is really an area that's obviously almost becoming the standard practice nowadays. So do all guidelines routinely recommend NIPT for twins? Well, I put a list of the international guidelines, and you can see that now more and more of these guidelines are recommending NIPT or self-free DNA in twins. You've got the Americans, ISOUG now is recommended, FIGO, that was say more evidence, but FIGO was published back in 2016 and currently will be updated. ISBD does recommend it, and ISOUG, there is a draft guideline for NIPT, and it's likely the draft is a further evaluation needed because of the numbers. But as it's just a draft, it's not the final version. Okay, so what about invasive prenatal diagnosis? So suppose you've done the screening, it's high risk, or you've done the scan and already there's discordant anomaly or discordant nuchal translucency. What form of invasive prenatal diagnosis is recommended in twins? And in the guideline, we did recommend that CVS should be the preferred option compared to amniocentesis, and the main reason it allows you to have an earlier prenatal diagnosis, and that means you could offer earlier, safer, selective termination if this is what the parents want, compared to waiting to the second trimester. In monocorial diameter twin pregnancy complicated by discordant anomaly, I think it's better to consider the option of amniocentesis or double amniocentesis compared to CVS because of the rare circumstances where you have heterokaryotype. So it's different genetic diagnosis in each baby. What's the latest evidence in this area is the risk of miscarriage or pregnancy loss before 24 weeks and the preterm birth less than 32 weeks in early versus late selective termination. In diagonic twins, if it's before 18 weeks, it's only 1% risk of loss or miscarriage. And if it's after 18 weeks, it's about 8%. And the risk of preterm birth less than 32 weeks is 3% versus 20%. Does amniocentesis increase the risk of miscarriage? And again, when we looked at the data, it doesn't seem to be the case. This is a meta-analysis. The risk of miscarriage in twin pregnancies undergoing amniocentesis was 2.4%, but also the risk of miscarriage or pregnancy loss, overall fetal loss, and those who did not undergo amniocentesis was also 2.4%, so similar. What about the CVS? And again, in the meta-analysis that we published, there was no really difference. It was 2% versus 1.8%. And therefore, we did say, well, actually, the fetal loss following CVS in twins is lower than previously reported. And it actually does not really differ between those who twin pregnancies undergoing invasive procedures compared to twin pregnancies that did not undergo invasive procedures. But of course, there is controversial evidence in this area, whether adjust for the risk factors, but certainly one needle versus double needle or one entry versus double entry, it doesn't seem that there is a significant difference. Screen for preterm birth in twins, there is some changes in the updated version of the guideline. We do recommend doing cervical length assessment, and it's the most accurate form or method is transfusion ultrasound scan. In the second trimester between 18 and 24 weeks with a cutoff of 25 millimeters to actually determine the increased risk of preterm birth. Okay, what should I do if a twin pregnancy with a cervical length less than 25 millimeter? In this case, we do offer cyclogest or progesterone. What about if a woman who had additional risk factors? So she had a previous preterm birth, singleton, and now she's pregnant, or twins, and now she has a twin pregnancy. Should I do longitudinal assessment? Should I repeat the cervical length? Should I do just one-off cervical length assessment? And in the guideline, we did say that maybe we should repeat the cervical length at least once before 24 weeks, because if there is progressive cervical shortening. And this, as you can see, this is the data from the meta-analysis supporting the role of cervical length as a good predictor for early preterm birth in twin pregnancies. As I mentioned, what should we do if you have a short cervix? The data suggests that we should offer progesterone, natural progesterone, so that's a cyclogest vaginally or rectally. And as I said, that prophylactic use of it should be considered in twins with short cervix, but not routinely. So not to give it to all unselected twin pregnancies routinely, which some people do. What about the women presenting with a dilated cervix in the second trimester, so 1 to 4 centimeter before 24 weeks? This randomized control trial, I appreciate, is quite a small trial, but in this small trial, which we stopped early because of the fact that there was a large, significant difference, it was unethical to continue to randomize these patients. But in this small RCT, it's not perfect, but it's still an RCT. Certainly, the patient that were randomized to emergency cerclage or physical exam indicated cerclage with antibiotics and with indomethacin had significantly lower risk of preterm birth compared to expected management. So relative risk, let's say, for example, less than 28 weeks, 40% in the group that has cerclage, 84% in the group that had expected management, about 50% reduction. So actually this, considerably a very positive results, and also reduction in the perinatal loss. So I think, or the perinatal mortality. The latest evidence in this area, this meta-analysis that we published in PLOS Medicine, we looked at the data on cerclage in twins and also in women or twin pregnancies presenting with a dilated cervix, but also we looked at the one that very short cervix, less than 15 millimeter. And when we combine the data together, you see similar effects. So it seems that the cerclage is potentially beneficial in prolonging the pregnancy, reducing the risk of extreme preterm birth. And also here you see that's reducing the risk of perinatal loss or composite adverse outcomes. Perinatal loss by about 60%, more than 60%, and composite adverse outcome by about nearly 30%. I appreciate it's mainly observational data, but it still looks promising. And therefore, in the guideline, we did actually comment that if you have a twin pregnancy presenting with a dilated cervix less than 24 weeks, that you could consider or offer the emergency cerclage with antibiotics and tocolytics. And then also we did say that it may be considered if in twin pregnancies with a very short cervix, 50 millimeter or less. What about fetal growth? How do you assess fetal growth in twins? Obviously, there are many formulas. And some people said, well, scanning twins is difficult. Why don't you just lose the abdominal circumference or the only, rather than estimating the whole estimated fetal weight? And in fact, if you compare the various equations, certain equations that have a combination of head biometry, abdominal biometry, and female length to calculate the estimated fetal weight is more accurate. And certainly the Hadlock formula is still the most accurate. And if you have discordance, which is very important that you calculate the estimated fetal weight discordance every scan from 20 weeks, is that if it's 25% or more, that we recommend early referral to tertiary fetal medicine center. Not necessarily treatment, but referral for further assessment, Dopplers, and monitoring closely. And certainly, how do you diagnose selective fetal restriction? In twins, we often say selective fetal restriction because it's rare that both babies are restricted. It happens, but it's really rare. Most of the restriction in twins affects one baby, more than 90%. And therefore, you often see the term selective fetal restriction. How do you diagnose it? Is when you have one baby with estimated fetal weight less than 10 centile plus discordance of 25% or more, or sometimes discordance of 20% was also acceptable by some guidelines, increase or highlight that this pregnancy at risk of adverse outcome and therefore needs more frequent monitoring, so maybe weekly scans or every 2 weeks in the acquired twins. So diagnostic criteria of selective fetal restriction, that was the Delphi that we published a few years ago and now almost becoming the standard, is that if we have one baby with estimated fetal weight less than 3 centile, that's enough to diagnose selective fetal restriction, whether in dichorionic or monocorial twins. But if you use the conventional cutoff, most of us use this, the less than 10 centile, because often the software that you have might not give you the precise centile. If you use the conventional cutoff of less than 10 centile, you need to have, in addition, discordance of 25% or more, or abnormal umbilical artery Doppler. How do you manage these pregnancies? How often should I see them? And when should I deliver them? In dichorionic twins, most people would say just manage them as singleton. That's true to some extent, but with a caveat that I'm going to share with you in a second. But actually, it's just the fact that we don't have a lot of evidence on managing this pregnancy. So that's why we manage them as singleton. But there are some differences. For monocorionic twins, it's a bit more complicated because the fact that they share one placenta, and therefore, if the smaller baby is to die, there is about 30% risk that the larger baby would also die or have brain damage. And therefore, they're much higher risk pregnancy. They really need to be monitored very closely and by specialists. So the options for selective fetal restriction in monocorial twin pregnancy is either monitor, so conservative and early delivery, or active fetal intervention in the form of laser ablation or cord occlusion. How often should I see these pregnancies? Remember the monocorial twins, if they are uncomplicated, you see them every 2 weeks, correct? But if they are complicated, selective fetal restriction, we recommend it at least weekly, sometimes even more often later in pregnancy. And in dichorionic twin pregnancy, complicated by selective fetal restriction, every 2 weeks, sometimes more often if there is abnormal Dopplers. Certainly, if you're managing a selective fetal restriction in monocorial twins and you have evidence of substantial risk of fetal demise in the smaller baby, so abnormal ductus venosus, reverse A-wave and ductus venosus, which will indicate increased risk of demise of this baby, you need to do something. And this something, it depends on the gestation. So if it is after 26 weeks and you work in a country where you can have access to early neonatal care, so have high-level neonatal units, in this case, you consider delivery after steroids and magnesium sulfate for neuroprotection. If it is early, before 26 weeks, where you think if you deliver this pregnancy, those babies likely to die, in this case, we should consider active fetal intervention, either laser or selective termination. When you deliver these pregnancies in monocorial twins with selective fetal restriction, depends on the type, and we have the Gratakos classification. So type 1, when you have the positive indostolic flow in the umbilical artery Doppler of the smaller baby, the good type, low risk of progression, low risk of demise of the smaller baby, we can reach out to 34, 36 weeks. While in type 2, which you have absent or sometimes reversed endostolic flow in umbilical artery Doppler of the smaller baby, that's the worst one, high risk of progression, high risk of demise, the smaller baby, and the consequences on the larger one. Or type 3, when you have this unusual pattern of intermittent reverse endostolic flow in umbilical artery Doppler of the smaller baby, again, unpredictable with the risk of demise of the smaller baby and the consequences on the larger baby. So type 2 and type 3, we suggested to delivery at 32 weeks or earlier if there are signs of deterioration. That's not really based on a randomized control trial. That's just based on observational studies and consensus opinion. I mentioned choose selective fetal restriction in dichorionic twins. Many people would say just manage them as singleton. Well, yes, but that's not really supported by evidence. I think what's clear is that before 29 weeks or even 30 weeks, we would really strongly advocate expectant management, so not to deliver because of the risk of iatrogenic prematurity to the larger twin, which is the healthy one, the one that has slightly better prognosis. Of course, if the woman develops preeclampsia, you have to deliver for maternal indication. But certainly before 29 weeks, expectant management. After that, you see the threshold for delivery is actually very similar to the threshold for delivery in singleton pregnancy with fetal growth restriction. And then this was added to the new guideline. This is with no evidence whatsoever, but this is the same concept of the fact that manage them as singleton fetal restriction. As I mentioned, that's not supported by any evidence at all, but this is if you use computerized CTG, that's the cutoff according to the STV, the short-term variation, in the computerized CTG. As I said, applying just the fetal restriction in singleton, but that's not supported by evidence. What about if you have single intrauterine demise? Well, of course, it's a very sad situation, and often you have to counsel the parents. Often there's a pressure on you to deliver early because they worry about the baby that's alive. And I think you really should resist hard early delivery because it's not necessarily beneficial unless you have evidence that the baby that's alive will die, abnormal heart monitoring, abnormal CTG or something. In this case, you really need to resist the desire or the temptation to deliver this baby because of the risk of iatrogenic prematurity. What should you do? Well, you should, number one, do the detailed ultrasound scan looking for the cause of the death. So if it's monocorial twins, there is TTTS, polyhydramnios, oligohydramnios, for example. So that may be acute form of TTTS. We missed the TTTS, for example. But in terms of the risks that you need to probably counsel the parents is the risk of demise of the co-twin, the surviving co-twin, the risk of preterm delivery, the risk of postnatal brain abnormalities in the surviving twin, the risk of neurological abnormality. And you see here in monocorial twins versus dichorial twins, monocorial twins are always much higher, of course, compared to dichorial twins, except the risk of preterm birth. We can see that both actually high. Yeah, so the risk of preterm birth is very high, and therefore, certainly, and traditionally, if the pregnancy is beyond 24 weeks, for example, and is still premature, people would consider giving a course of prophylactic steroids. But certainly, with the trend of moving away from giving routine steroids, I think people are trying to be a bit more sophisticated in terms of triaging who the pregnancies that would be really high risk of preterm birth. And then a few years ago, we actually wanted really to see this risk of preterm birth. Does it differ according to the gestational age of the single intrauterine demise? And here, this is a large data of more than 3,000 twin pregnancies, the historic data. And then if you see that the risk of preterm birth less than 34 weeks differed according to the gestational age at single intrauterine demise. So if it happens in the first half of the pregnancy, you see was a lot less compared to if it happened in the second trimester or if it happened in the third trimester. So in the third trimester was obviously the risk a lot higher. Yeah, so it differs. So if you have a single intrauterine demise in the first trimester, let's say in monocorial twin pregnancies, I think the risk of preterm birth is, yes, it's increased, but it's not very high and definitely does not warrant giving prophylactic steroids. So in single intrauterine demise in monocorial twin pregnancies, this is a useful flow chart about how you manage this pregnancy. So detailed scan, trying to look for the cause. You do the Doppler assessment, particularly the MCA big systolic velocity, because you're looking for the evidence of hyperdynamic circulation. And many centers would consider giving transfusion if there is a recent demise and there is high MCA big systolic velocity in the surviving twin. You counsel the patient, and then you still need to do an assessment biometry Doppler every 2 weeks because this pregnancy is still at risk. And then we do an MRI 4 to 6 weeks after the diagnosis of single intrauterine demise, looking for brain abnormalities. There's no point doing the MRI straight away because you're not going to see things. You need to give time for the damage to become obvious and detected by imaging. And then we still deliver at 34 to 36 weeks because of the residual risk. We give steroids, but this is not supported by strong evidence. And then we do offer post-mortem examination of the baby that died and placental examination of the placenta. Complication unique to monocorial twin pregnancies. I mentioned the TTTS, the selective fetal restriction monocorial twins, which I already just covered, the TAPS, and then the TRAP. So let's cover them and share with you the recommendation of the updated guidelines. So TTTS is an oligohydramnios polyhydramnios sequence. How do you diagnose the oligo? When you have the deepest vertical pocket less than 2 centimeters, regardless of gestational age. But if you have the polyhydramnios, depends whether you are in the States or in Europe. In the States, it's just the 8 centimeter cutoff to diagnose polyhydramnios in the recipient twin. In Europe, we have different cutoff. So before 20 weeks is 8 centimeter, after 20 weeks is 10 centimeter. And a few years ago, we proposed that before 18 weeks, you should use 6 centimeter diagnosed polyhydramnios in the recipient baby rather than the 8 centimeter. And that was supported by the fact that if you look at the reference chart, the 8 centimeter cutoff for polyhydramnios before 18 weeks is too high. And we all have come across cases where you have typical features of TTS, normal Doppler, the cardiac changes, but the deepest vertical pocket does not reach the 8 centimeter cutoff. And most people nowadays for early TTS are using the 6 centimeter cutoff, not the 8 centimeter cutoff. How do you stage? So once you make the diagnosis of TTS, we have the Quintero staging. It's not perfect, has been criticism, but it remains to be the most common classification system that's used. And of course, if you still seeing the bladder and the Dopplers are normal, that's a stage 1. If you're seeing polyhydramnios, oligohydramnios, you've been scanning for a long time, you can't see the bladder in the donor, that's a stage 2. Once you have abnormalities of the Doppler, that's a stage 3. And the typical Doppler abnormalities would be abnormalities in the umbilical Doppler in the donor, abnormalities in the ductus venosus in the recipient. And then if you have hydrops or one of both babies, often the hydrops is in the recipient, that's a stage 4. And you have demise of one of both babies, that's a stage 5. So remember I mentioned earlier in the flow chart that we should monitor monocorial twin pregnancies every 2 weeks because we're monitoring for the TTTS, measure the deepest vertical pocket. And I did also mention you need to know the diagnostic criteria, but also you come across many cases where there is discordance, but it does not reach this diagnostic criteria. So are these pregnancies still at risk? How should I monitor them? And certainly if you have amniotic fluid discordance and how you define that, traditionally people would use it when you have difference in amniotic in the deepest vertical pocket of 4 centimeter or more. They still have risk, but the risk is small. So the low risk of progression to severe TTS is only about 15% will progress. In these pregnancies, outcome is very good. The overall survival is more than 90%. So you need to be reassuring for these patients that you need to see them weekly to look for progression, at least for 4 or 5 weeks. Okay, so we know that in TTTS, the recommended first line is laser because that's supported by randomized control trials, and Cochrane reviews to say that laser is better than amnio reduction or amnio drainage, better survival, low risk of disability. What about for stage 1 TTTS? The evidence is all about stage 2 or higher, 2, 3, 4. What about stage 1? Should we offer laser routinely? And the answer is no. This was a randomized controlled trial that included stage 1, asymptomatic, 16 to 26 weeks with a cervix that's more than 15 millimeters, so a long cervix. The trial was stopped early because they had difficulty recruiting after 7 years, but the trial found no difference in outcome between doing the laser straight away or expectant management monitoring, and if it progresses, you offer laser. Therefore, there's no point in offering laser surgery for stage 1 TTTS asymptomatic with a long cervix, only if they progress or they become symptomatic or they have short cervix. Of course, for TTS, as I mentioned, laser is recommended for stage 2, 3, and 4, and conservative management for stage 1 asymptomatic with long cervix. If there is any role for serial amnio reduction or amnio drainage, and the answer is yes, particularly if you work in a healthcare system where you don't have access to laser, and if it's beyond 26 weeks. And certainly cases, sometimes we have acute TTS in the 3rd trimester, and in this case, we don't always do laser, sometimes we do amnio drainage. When you deliver these pregnancies, and the recommendation, we kept the same recommendation in the previous version, 34 weeks, because we didn't have any evidence otherwise. But this is also controversial because, and this is not supported by a randomized controlled trial. The reason why 34 weeks, because there's a potential residual risk for these pregnancies. But there are certainly some centers where if the pregnancy remains uncomplicated, they might carry on until 36 weeks. In my practice, I deliver them at 34 weeks. And we move on with another monocorionic complication or monocorionic twin pregnancy complication, which is the TAPS, twin anemia polycythemia sequence. So one baby is anemic, pale, another one is red. There's a lemonade blood. This is a ketchup blood. It's an easy way to explain it to the parents. and it's occurs because of the very, very tiny anastomosis, intertwin anastomosis, that allow the passage of the red blood cells from the anemic twin, the donor, to the polysystemic twin, the recipient, with no discordance in amniotic fluid volume. Um, it occurs, most of the cases of TAPS occur post laser, but there is still also some cases that occur spontaneously. The diagnostic criteria started postnatally when there's a large hemoglobin difference, more than 8 gram, with difference in the reticulocyte or the count ratio more than 1.7, and this having this tiny anastomosis in the placenta less than 1 millimeter. That's been transferred to diagnostic criteria antenatally for us. We can detect it by ultrasound scan to the anemic one, peak systolic velocity in MCA more than 1.5 millimeter, and the recipient is less than 1 mom. That was the initial diagnostic criteria. But that's been questioned by a number of researchers, because this diagnostic criteria, less than 1 mom for the polysystemic twin, more than 1.5 mom for the donor or the anemic, has sensitivity only of less than 50%. That means you miss some cases of TAPS. Specificity is 100%. So once you have it, it's TAPS, but you miss a lot of cases that have TAPS. And therefore, the Dutch team suggested or proposed to use the cutoff. So rather than individual cutoffs, you use this difference in the peak systolic velocity in MCA, so the delta. And they suggested that if you use a difference of 0.5 mom, you increase the sensitivity from 46 to 83%. So you pick up more cases. The German, so Professor Kurt Hecker, suggested even 0.373, so even a lower cutoff to increase the sensitivity even further to more than 90%, that you start losing the specificity. So that created a lot of confusion, which diagnostic criteria to use, and then we published the Delphi, which I think is a very reasonable diagnostic criteria because it reduces the false positive to the cases that not necessarily really TAPS, and you end up by sort of monitoring a lot of them and they're fine, and also not missing cases of TAPS. So the Delphi, you 1.5 mom for the anemic, but instead of the 1 mom, you go lower, so 0.8 moms, so more severe cases. And also you include the discordance of 1 mom instead of the 0.5 mom. I hope I didn't confuse you. The TAPS, there is a number of management options for TAPS. There's no robust evidence about what's the best management option. There is an ongoing RCT called TAPS, led by the Dutch team, which is randomizing to either laser or other intervention. But certainly the management option that we have is from expectant management, which is reasonable in stage 1 or mild cases of TAPS, to preterm delivery. So that's in TAPS, that's after 32 weeks. I think it's reasonable to give steroids, magnesium sulfate, and deliver, or laser surgery, similar to what we do for TTTS, or transfusing the anemic twin and partial exchange or diluting the blood for the polysystemic twin, or selective termination, particularly if there is discordant anomaly or one of them is hydropic. But it is tricky because, as I said, when you see more cases, many cases of TAP, sometimes it's not as straightforward. And certainly because you don't have a clear evidence to support your intervention. So the TAPS registry, where we had about 300 cases, more than 300 cases of TAPS, you see this is the risk of perinatal mortality, that's for counseling, severe neonatal morbidity, according to the 5 management options that I showed you: expectant, laser, transfusion, selective termination, or early delivery. And you can see the perinatal mortality is not hugely different, actually. Obviously, only the selective termination, but by definition, you lose 1 baby, yeah? So the 7%, just be careful because you only have 1 baby left anyway. And the severe neonatal morbidity is similar also. There's not really massive difference between the various intervention. Again, the selective termination has the lowest because also you only have 1 baby left. But if you see the time between the diagnosis to the delivery, you see that actually there are difference. So here the selective termination, of course, they have the longest period, so followed by the laser, followed by expectant management, followed by the transfusion. So there might be difference. So the TAPS trial is randomizing TAPS cases, stage 2, to either laser or other form of intervention. And then it's still ongoing trial, so we don't know the results yet. So what did we include as a recommendation in the ISOUG guideline? We did recommend that you look at the MCA Doppler routinely from 20 weeks. If there's discordance, you should obviously consider the diagnosis of TAPS. And we did acknowledge that the fact that we don't have robust evidence on what is the best management, and therefore the management should be individualized. We did recommend that we should be monitoring for or screening for TAPS, and the fact that in all cases of monocorial twin pregnancies, even uncomplicated, and certainly all cases that had laser for TTTS. We also recommended that there is a form of prevention. So in order to try to reduce the risk of post-laser TAPS, in this case, you should do the Solomon technique to reduce the risk of post-laser TAPS. The monitoring of TAPS, as I mentioned, so from 20 weeks, we did recommend that we should do the MCA victory in all twin pregnancies. Finally, what about the TRAP, or twin reversed atrial perfusion, which is nowadays should be really diagnosed in the first trimester. So this is a twin monocorial twin pregnancy, and it can happen in either diamniotic, but also can happen in monoamniotic twin pregnancies, where you have the pump twin completely normal anatomically, but you have another, which is a trap, which is often quite malformed twin, malformed fetus with often no cardiac pulsations, but there is a reverse flow in the trap mass, and the risk is mainly really that the bump twin, because of this extra volume on the heart, suffers heart failure, and therefore risk of demise of this of the bump twin. So the key features is one twin is normal, the other one is very malformed with various forms of malformation. Often the lower limb is the one that's only present, and then the keys, no cardiac pulsation. The key thing is to demonstrate the reverse flow in the trap mass. The management options is either doing nothing, and there is a risk of losing the bump twin, or offering a form of fetal intervention, and this could be from either doing a laser, intrafetal laser, very simple procedure done in the first trimester under ultrasound guidance, or doing radiofrequency ablation, again it's ultrasound guidance, or doing the laser, like what we do, fluoroscopic laser ablation, like what we do for TTS, or cord occlusion of the trap, but often it's not easy because they tend to have very short umbilical cord. Regardless of the intervention, really the survival rate has been quoted about 80%. The controversy about the intervention for TRAP is mainly about the timing. Do you intervene in the first trimester? Often most cases are now diagnosed in the first trimester, so you do intervene in the first trimester once you make the diagnosis, or do you wait until 16 weeks? And the rationale behind waiting is, of course, first trimester intervention could be associated with risk of miscarriage, and the fact that some of them will have spontaneous cessation of the blood flow in the trap mass, so that's maybe suggests that it's okay to wait until 16 weeks. But actually the downside of the rationale behind interfering in the first trimester is that while you're waiting between 12 and 16 weeks, there is you lose a significant proportion. So when they come back, you have a demise of the bump twin, which is quoted about 60%. And therefore, that's the rationale behind this TRAPPIST trial, randomized controlled trial, randomizing to early versus late intervention, and because of this potential risk of losing the bump twin between the first trimester and the second trimester. So I hope that I did really a very quick overview of a massive guideline and shared with you sort of the most important recommendation in the guideline. I hope that I didn't rush through it, but it was a lot to cover. So I'm going to stop here. And of course, as I said, I will encourage you, if you have any questions or comments, just put them in the chat, and I'm sure we will have a lot of discussion at the end of the webinar. Great, thank you very much. So Professor Lung, are you able to share your screen or not?
Yes, I'm ready.
Fantastic, perfect, okay. So we're gonna move on. I've already introduced Professor Lung. It's a pleasure to have you. with us in the webinar today, and his talk will be focusing on the non-invasive prenatal screening or self-reading in twin and higher order multiple pregnancies. Thank you very much.
Thank you. Good morning, everybody. So I'm going to share with you the use of NIPS in twin and high orders multiple pregnancies. As you may have known, I work in the Chinese University of Hong Kong, where the NIPS was originated from. I worked closely with Professor Dennis Low on this NIPS. Now, so this is a meta-analysis published in 2022, including 28 studies reported on the 50 cases of true positive trisomy 21 cases in twin pregnancies. And you can see here, compared with singleton NIPS for twin pregnancies for trisomy 21, can achieve a detection rate and false positive rate closely to that of singleton. However, for trisomy 18 and 13, the sensitivity and the false positive rate is lower than that of singleton. But nevertheless, right, NIPS for twins is more accurate than first trimester combined screening, right? Which have only about 80% detection rate with a false positive rate of 5 to 10%. However, the main challenge is how to differentiate the cyclicity and what is the accuracy in different cyclicity that this meta-analysis has not addressed. Now, just a recap. Now, if it is a monocyclotic twins, we suppose that the twins have the same genotypes, and therefore they will be either both of them may be either normal or both of them are abnormal. And we can treat these monocyclic twins as singleton pregnancies, and theoretically, because of two fetuses, the fetal fluorescence actually will be higher than that of singleton. Now, in case of dicyclotic, we suppose that the genotypes could be different. So the twin pairs could be either both of them normal, one of them abnormal, and very rarely both of them are abnormal. Now, in case that one is abnormal, the DNA released from the normal fetal placentas will dilate the fetal fluorescence of the abnormal one and increase the chance of a false negative. Now, so you have to remember these slides, which is very important. Now, so the x-axis is the fetal fluorescence and the y-axis is the Z score. Now, if it is a new point pregnancy, singleton pregnancies, the Z score should be within the range of -3 to 3. If it is a trisomy 21 pregnancies, then the Z scores increase with fetal fluorescence. And if the fetal fluorescence is less than 4%, a critical threshold, it's possible that even if it's abnormal, the Z score will fall below 3 and cause a false negative result. Now, if it is a twin pregnancies, we usually measure the total fetal fluorescence, right, shown here. Now, but then one of the twins may have a lower fetal fluorescence than the other, right? And in case one is abnormal and the fetal fluorescence of it is less than 4%, then you may miss these abnormal co-twins. Now, so to deal with this problem, what can we do? How can we ensure that individual twins' fetal fluorescence are adequate? Now, so we may consider to set up a high threshold. For example, for singleton, we use 4%. For twin pregnancy, we use 8% or even 10%. But then, if we use a higher threshold, we may have a higher non-reporting rate. And secondly, the fetal fluorescence are not equally shared between the two co-twins, right? So if you take 8%, not necessarily both of them are at 4% level, right? Some may be lower, some of the coaching will be higher. So it still cannot guarantee a good quality of your test. Now, so how can we assess the individual twins' fetal fractions? Now, we can use the Y chromosome DNA, but it can only be applicable if in the twin pregnancies, one of them is a male and the other is females. Otherwise, you can't use this method. The cell-free DNA fragments length, and we know that shorter the length, the more likely will be from the fetus. But then it cannot tell you the different twins. Same for methylations, right? Now, so the only ways to differentiate the twins is using this SLEEP method, single nucleotide polymorphisms. Now, what is that? We know the nucleotypes are the ATCGs, right? And sometimes we may have a single nucleotide change, right? This change is usually occur in the non-coding regions, and therefore, even if there is a variations, it's seldom cause disease, which is non-pathogenic variations. Now, it can in many sites in all chromosomes. So, and individuals may have different SNP, right? And you can label it SNP 1, 2, 3, and so on. Now, so two alleles for each SNP can be denoted by A and B, right? Now, in case the mother may have a SNP that is AA or AB that is different. Now, we just focus on those SNP that on the maternal side, they are the same. And then for the paternal side, it could be AA, AB, and BB. So that for the fetus, the inheritance pattern will be either AA, same as the mother, or AB, which is different from the mother. Right? Now, so for this particular SNP, right, we may identify that some may be the same as the mother, which is non-informative, and some SNPs will be different from that of mother, which may help us to differentiate the fetal fraction from the mother. Now, so if it's A fetus is AB, then the total uh, um, uh, portions of the fetus, right, can be calculated in this way. Okay. Now, so let's say the mothers have different SNPs, right? Labels are 1 to N, and if it's a singleton, then the fetus may have the same as the mother or have a different SNP from the mother. So the same one are non-informative, while the different one will be informative, and we can calculate the fetal fractions. Right? Now, let's say it is a monozygotic twins, right? As we mentioned that the monozygotic, the genotypes are the same, and therefore, uh, all the SNPs will be concordant between the twins and could be different from the mother, right? And in this way, we will be able to identify that if it is the same, right? Then we will be able to confirm that it is a monocyclic twins. Now, when this is a paper we published 12 years ago, right, to demonstrate this principle, right? So this is a 4 pairs of monocyclic twins, and you can see that, right, all the fetal fractions measured by the state are quite consistent, right, over all the state, right? This is one of the monocyclic twins, and this is the other monocyclic twins, right? So this is all concordant. Now, but let's say it is a dicyclic twins, right? Then the twins pairs could have different SNPs. Some may be the same, concordant between the twins, right? Some may be discordant between the twins, right? Now, so in this situation, then the fetal fractions measured by the different SNPs will be fluctuate, right? So you can see here 4 pairs of dicyclic twins, and you can see the fluctuations, right? So some will be the same, and therefore the calculated fetal fraction will be higher. Some this will be discordant, and therefore will be lower, right? So this is a discordant pattern. Whereas in monocyclic twins, this more concordant, right? Now, so using this sleep method, we will be able to differentiate whether it's monocyclotic and dicyclotic. And we can also calculate the total fetal fractions as well as the individual twins fetal fractions in this way. Now, so this is a paper we published some 12 years ago, and we confirmed that using this method, we'll be able to differentiate dicyclotic and monocyclotic twins, and we measure the fetal fractions using sleep and other methods, right, which is concordant. And we also identified that in two pairs of twins, one of them is a trisomy, and it shows a higher set score. Now, so this is one of the case, and the set score is on here. Now, this is the total fetal fractions, and you can see that right, the set score is not concordant with the total fetal fractions, but concordant to one of the twins fetal fractions. And in this way, we'll be able to tell that the NIPS is positive and pointing to that one of the dicyclic twins is a trisomy. And this is the same for the second case, right? So the expected set score is here, but actually it's there, and it is more correlated to one of the twins fetal fractions instead of the total fetal fractions. Now, so using sleep analysis, we'll be able to identify the cyclicities as well as the fetal fractions contributed by individual twins. And we also know that whether one or both of them is aneuploidy or not. And of course, we still don't know which twins is abnormal. We still require the ultrasound to identify which one is abnormal. Now, so this is a paper published some years ago, just to show that among the normal monocyclic twins and dicyclic twins, what is the distribution of the fetal fractions compared to singleton. Now, so regardless whether it's monocyclic or dicyclic, when we compare the singletons, the mean fetal fractions is higher than that of singleton by about 1/3. And we just look at monocyclic twins, combined fetal fractions versus singletons is similar, about 1/3 higher than singleton. Dicyclic twins also similar. And if we look at individual twins in dicyclic pair, then you can see that it is lower than that of the singleton, about 1/3, right? And compare monocyclic and dicyclic twins, they are similar, right? Now, these findings indicate that if you use a singletons as a reference, as one individual dichogonic twins, then usually the fetal fraction is about 2/3 of that of singleton, right? But then combined to a total fetal fractions, then it is 2/3 plus 2/3 will be 1 and 1/3 higher than that of the singleton. Now, so based on this, as we have mentioned, right? If we want to have a reportable NIPS result, the fetal fractions must be at least 4%, right? So each one must be at least 4%. Now, so here indicate that now if the total fetal fraction is more than 10%, the chance that one of the fetal fraction is less than 4% is rather low, 2.8% only, right? If both of the fetuses have a fetal fractions lower than the threshold, the chance is very, very low. Now, if you use the threshold of 2.8% as stated in some of the companies, then the chance is 0.59% and 0% respectively. Now, but if the total fetal fractions fall into range of 8% to 10%. Now, then you can see that is higher chance that one of the fetuses may not have a fetal fluorescence uh, adequate enough for the analysis. Now, the chance is 45%, right? It's quite high, right? Now, if both of them are less than 4, then the chance is still low, right? But you don't want to miss anyone, right? So 8 to 10% is not sufficient. If you use a lower threshold of 2.8%, then it is 2.3. The chance is 2.3%. Now, if the total fetal fluorescence fall into 6% to 8%, then uh, uh, the chance that one of the fetuses have a fetal fluorescence less than 4% is 42%. And both of them have a insufficient fetal fluorescence is actually very high, 60%, right? And if the total fetal fluorescence is fall into the range less than 6%, then very likely that it is a non-reportable, non-reliable uh, uh, analysis. So based on this, right, for twin pregnancies, right, the total fetal fluorescence should be at least 10%, right? And this also shows that the trend of the fetal fluorescence in relation to gestational age. And this is a singleton, slightly increased with gestation, and this is monozygotic twins, and this is dizygotic twins. And this is the fetal fluorescence varies with the maternal weight. And you can see that both twins and single pregnancies, fetal fluorescence fall with the obesity of the mother. So this is a paper published some years ago, a retrospective study of about 19,000 twin pregnancies, and 1.1% of them are found to be high risk, and 105 cases have the follow-up result available. And this is the result right here. And overall, if this is monozygotic twins pregnancies, they detect all of the 4 trisomy 21 cases. So for monozygotic twins, although this number is not very high, this indicates that the accuracy is high. But this is dizygotic twins pregnancies here. Right, you can see that the detection rate is only 88%, right? 88%, yeah. So this paper add into the previous meta-analysis that the accuracy on NIPS in different psychosity. Now, of course, we also concerned about vanishing twins, and usually if there's one abnormal twins, it may vanish, right? And these vanished twins may still have this placenta releasing cell-free DNA fragments, and that may affect the NIPS result. Now, so the abnormal vanished twins placenta may still release DNA, leading to false positive result for the remaining normal twins. And this may also cause some sex disconcordance. And so this is a paper published 10 years ago, right? So they have 30,000 cases, originally said to be singleton pregnancies, but actually using a split method, they identified 130 cases of vanished twins, right? And 5 of them have the timing of the fetal demise identifiable stage here. Gestational age range from 7 to 8 weeks, and this is the gestational age when the NIPT will perform. And you can see that the interval varies from 2 weeks to 8 weeks long. And this is the fetal fluorescence of the vanished twins, which can be assigned as 11%. And it seems that these fetal fractions may not very correlate to the time of demise as well as the interval between the demise and testing of NIPS. Right? Now, um, so it's still a chance in NIPS for a twin pregnancies with a Venus twins. Usually, we'll try to do the NIPS after a longer interval from the fetal demise. But of course, you need to individualize different cases, depends on the gestational age and so on. Now, this is papers on the Venus twins. Um, just to show that now, if this is a twin pregnancies with one vanish, if you have a positive NIPS result, the chance of having a true positive or for the remaining twins is 20%. Another 71%, the positive result could be actually from the vanish one. And this is transmit 21, and this is transmit 18. Right? If you have a Venus twins pregnancies, if you have a positive result for transmit 18, then you will be 38% chances from the remaining twins, while 54% chances from the Venus twins. And same for transmit 13 here. The chance that you'll be from the Venus twins is as high as 86%. So in that case, what is our management options? Now, of course, right, if you have a positive result, you want a definite diagnosis, then no way but to do an invasive diagnostic procedures, probably by immunocentesis. And you may also consider, right, to monitor the trend of the fetal fractions as well as the trend on the sex score, which is declining with time. Then it may indicate that the positive results could be from the Venus twins. And then if it turn out to be negative afterwards, then you may consider not to proceed to an invasive diagnostic test. But then you also have to bear in mind the Venus fetuses could happen in multiple pregnancies, right? It could be a triplet to start with one Venus or two Venus. Now that may also make the NIPS more complicated, right? So it is IVF pregnancies, you have to know how many embryos has been transferred into uterus. Now, there's also an interesting finding from sleep NIPS. This is a report from 9,000 twin pregnancies with NIPS. Now, using the sleep, we want to know whether it's monozygotic or dizygotic, and whether it's concordant with the ultrasound finding. Now, so if you find that it is okay, it's a twin pregnancies, and using the sleep method, you will find that about 1/3 of them are monozygotic, 2/3 of them are dizygotic. Now, if you do a ultrasound and find that it is DCDA twin pregnancies, right? It could be either monozygotic or dizygotic. Then you can see here, nearly 90% will be dizygotic twins, while about 14% will be monozygotic. Now, if you do an ultrasound but you can't identify the congruenicity, then the chance will be 1/3 monozygotic and 2/3 dizygotic. Now, more interesting is that if you think that under ultrasound, it is MCDA, right? Of course, we it's supposed that all of them should be monozygotic. But in this report, it shows that whilst majority are monozygotic, there's 5% chance it will be dizygotic. Now, this is very interesting finding. If you do ultrasound, you find that it is MCMA. Again, it's supposed to be monozygotic. Then, uh, actually, 19% are dizygotic. I was surprised with this result. How can we explain this? Now, of course, one of the possible reasons is that this is a retrospective study, and the data is drawn from the database, and that could be a wrong entry or wrong ultrasound assessment. But of course, there's also some special situations that dizygotic twins, right, could develop into MCDA placenta, or even some interesting situations. Now, you may refer to my review papers published in AJOGs and in the best practice research clinical energy, right? I discussed about the pitfall in assessing the immunicity with ultrasounds in these two papers that you can refer to. Okay, now, what is the other use of NIPS? Now, for example, if you have selective fetal growth restrictions, one baby is bigger than the other, but then you're not certain about the chorion immunicity, right? Because the lambda sign is absent, and it's hard to differentiate whether it's monochorionic or dichorionic. And you may have to intervene with selective fetal reductions, or you may have to decide uh, the prognosis in case one of them may die in utero. Now, in that case, you may perform NIPS with a sleep platform. Now, if the sleep tell you that it is dizygotic, then most likely that it is dichorionic. Then you think it will be that the twins are independent, and you don't worry one of them will be die in utero, or you can use a KCL instead of laser or radio frequency to do a fetal reduction. Now, of course, with the NIPS sleep method tell you that it is monozygotic, then it can still be DC or MC. Then you still have the chance in the management. Now, lastly, what is the diagnosis here? Here you see a fetus here, but one placenta and a mass there. What is the diagnosis? Now, in this case, you see a separate mass. You may think that it is a separate placenta, but it is more cystic in nature. Now, so you may suspect that it could be a normal twin, or it could be twin pregnancies with one normal co-twins, but the other is a molar. Right? Now, this situation, right, could be a dizygotic twins with one disomy and one molar pregnancies. Now, sometimes it could be a monozygotic twins with triploidy. The fetus is a partial mode, and the placenta may present with these cystic features. Now, in this situation, you may also consider to do an NIPS, right, using a split method, which will be able to tell you that it is not a singleton, but a dicyclic twins pregnancies, right? Or it may be a single pregnancy, but it could be a triploidy. Right? Now, so the split may be useful in these situations, and in fact, this case report was published 2023, quite similar to my case I showed you. You can see that it's a normal placenta, normal co-twins, and this is sister placenta here. So this case also use the sleep method to identify that it is a co-twin with molar pregnancies. Now, okay, lastly, how about NIPS for high order multiple pregnancies? Now, unlike twin pregnancies, if you have a triplet or high orders, you may want to consider elective fetal reduction. And if you want to reduce the number of twins, you don't want to reduce a normal one, leaving the abnormal one, right? So in this situation, you may want to do an NIPS just to see whether any one of the triplets may have a maybe an aneuploidy. Right? Now, at this moment, there's not much data on NIPS with high order multiple pregnancies, but the principles is all about fetal fractions of individual triplets. Now, if it is a triplet result from spontaneous conception, which is very rare to have a tricyclic twin pregnancies, it's more likely to be monocyclic, one split into three, or two embryos with one split into two, and therefore end up with DCTA. Now, in this situation, it is either monocyclic or dicyclic. I think you can still perform NIPS, right? But you need to talk to the companies that offer the NIPS report. Now, if it is triplet result from IVF, then you could be tricyclic. Now, of course, we can prevent this happen, right? We should restrict the number of embryo transfer to one or at most two to avoid tricyclic twin pregnancies. And we may also consider to do PGS before putting it back, so as to minimize the chance of having aneuploidies in multiple pregnancies. This is more on the prevention side. Now, if you really have a triplet, you want to do an NIPS, you need to do ultrasound to determine the choromicricities and look for any fetal malformations, and then you may have to consider to do a sleep, and you may also have to use a high threshold for the fetal fractions and so on. Now, of course, after all, NIPS is just screening. It's just screening. You have to accept that there will be lower sensitivity and higher false positive rate. Okay, now so let me conclude here. NIPS in general is applicable in twin pregnancies. Accuracy is better than first trimester combined screening or second trimester biochemical screening. NIPS may need a higher threshold for fetal fractions, leading to a higher non-reporting rate. And sleep platform NIPS can differentiate the cyclicity, and if it is dicyclic, we can use this to estimate individual fetal fractions to ensure adequate fetal fractions for meaningful analysis. You can also use it to determine how many twins are affected, but you cannot tell which one is abnormal. You still use ultrasound to identify the abnormality. For vanishing twins, you may give rise to a discordant sex result or a false positive NIPS result. If you're suspecting vanishing twins, you monitor the trend of the fetal fractions and the sex score. And if choromicricity is uncertain, and it's important to note it for the management of, for example, fetal restriction, then you may also perform a sleep NIPS to assess the cyclicity. Modern pregnancies with coexisting with a fetus using sleep, it may also help you to differentiate if it is a normal fetus with a complete mole or a partial mole. Right. Thank you very much.
Thank you very much. That was what is this more? No, the screen.
No, finished. Yeah.
Okay, so I think we can unshare the screen. That was fantastic. Thank you very much. Really informative for a topic that's actually quite complex, and I think a lot of people find it difficult to navigate the interpretation of the the cell-free DNA, especially when you have a vanishing twin, should you offer it? Should you not offer it? What the guidelines show? Do you repeat it? How far did you repeat it? What about in triplet pregnancy? So I'm sure there will be a lot of discussion about that at the end of the webinar. So I hope you're able to stay with us. I know you're away, but I hope you're able to stay with us until the end of the webinar. Now we're gonna move to the cases, which is often very interesting part of the webinar. And it's my pleasure to introduce Professor Conrado Coutinho. I did actually introduce him earlier among the list of the speakers that we have. He have a list of really interesting cases that he will share with us. So Conrado, please go ahead.
So thank you very much, Asma, for having me here, for always remembering my name. Well, it's a pleasure to collaborate with you. Can you see my slides? Yes. And well, thank you very much also to ISOUG for supporting this activity. It's really hard to have nearly 1,000 people on a Sunday morning here in Brazil, at least. And well, let's try to talk a little bit about some interesting cases about twin pregnancies. So here is just to show where I am, Ribeirão Preto, near São Paulo in Brazil. It's a medium-sized city in Brazil, and this is my hospital in my university, University of São Paulo at Ribeirão Preto. And let's start with an easy question. It should be easy to define chorionicity, isn't it? So which one of these do you would rather to have as a patient? Well, I'm not sure if I'm going to, at this point, I'm not seeing the chat box, I'm only seeing my slides, but I'm completely sure that all of you would rather having the patient on the right as a patient, a dichorionic pregnancy with this full lambda sign, instead of a monocorionic pregnancy where we can see this T sign or sometimes an empty lambda sign without this trophoblastic tissue, indicating that here we have only one placenta and here two placentas. So I think this is the easy part of my cases, and Asma has already presented and showed the importance of defining chorionicity in every twin pregnancy. It will have an impact on how you are going to follow these pregnancies afterwards and the risks that may arise and that are increased in monocorionic twin pregnancies. So unfortunately, this is not that easy in low and middle income countries like my country. And many times what we have to do is to define chorionicity later on in pregnancy. So let's present this first case, a case of Mrs. A, 21 years old, first pregnancy, natural and conception and an unplanned pregnancy, nothing pathologic on her side, a BMI of 30. And this patient was referred to our service only because she was diagnosed with a twin pregnancy. And these are, she had two previous ultrasounds before arriving here in my service. First ultrasound, and here you can see that a very late ultrasound, 16 weeks and 3 days, BPDs same size, description of a single anterior high placenta, and it was labeled as monocorionic diamniotic. And then this patient had already another ultrasound, 24 weeks and 1 day, similar sizes, normal fluids, description of a single placenta, same-sex fetuses with normal Dopplers, and also diagnosis of a monocorionic diamniotic pregnancies. But unfortunately, no images were attached to this ultrasound report, so we couldn't analyze and look for signs of mono or dichorionicity at this point. And this patient arrives at our service with 26 weeks and 1 day. So this is my initial scan for this patient, 26 weeks. And as you can see here, both placentas are anterior high as previously described it, and they were continuous masses. It was apparently one continuous anterior placental mass. So everything goes similar to what was previously predicted by previous ultrasounds. And we also could confirm that the fetuses have apparently the same sex, so it's fine with monodi pregnancies. But have a look at this sign here. When I saw this, well, things got a little bit more complicated. Doesn't it look like a lambda? This was my first question, my first assumption. So is this really a monochorionic diamniotic pregnancy, or are we talking about a dichorionic pregnancy? But well, we are at 26 weeks. Lambdas are not common at this gestational age usually. But well, I looked more closely and it looked like a lambda for me. And then we carried on. And as you can see here, when you see monochorionic diamniotic pregnancy, you usually have to look for and to search for the membrane, the intermniotic membrane. It's not easy to see the intermniotic membrane, even at 26 weeks when you insonate these membranes vertically. And you can see here that when you insonate this membrane vertically, it's almost easy to see. It's relatively thick, almost 2 millimeters of the measurement of this membrane. And you can see here that it seems to have some separation of the membranes as well. Next thing I tried to see was really if I could differentiate the number of membranes. And you can see here that, of course, there are different layers in this membrane. So at this point in time, my opinion was that probably we were talking, so same size babies, normal fluid, apparently a single placenta anterior high, same-sex babies, but with an apparent lambda sign, and that I already mentioned before, is not that common at this gestational age. Usually the lambda sign disappears after 20 weeks of pregnancy. A thick membrane, almost 2 millimeters membrane, separation of the layers, and my opinion at this point in time was that it was not a monochorionic diamniotic case, but in fact it was more probably a dichorionic diamniotic case. And well, patient was we always have doubts in this at this gestational age. So I would like to know if you would follow this case as a monodi or a dichorionic diamniotic case. What is your opinion?
Are you asking everyone or are you asking me?
No. Well, everyone is invited to.
Yes, I think there is.
Unfortunately, I cannot see the.
Yeah, I can tell you. So Moses said dichorionic diamniotic, Dahra monochorionic diamniotic, Cucumber MCDA, Gafoor DCDA, Duddy MC. I mean, they're like, okay, they're mixed really. Some MCDA, some die.
Now I managed to open the chat here. It will cover my screen, but okay, we are trying to move on. So, well, I must say that at this point, well, this is so frequent in my country, asthma, so frequent that I have personally done more than 1,000 mid-trimester ultrasound in twins, and I'm really comfortable diagnosing chorionicity after 20 weeks of pregnancy. And we follow this pregnancy as die after this ultrasound examination. And in fact, what happened, these are the postnatal results of this baby. Male, nice weights at 35 weeks, but you can see here different blood types, and the pathological report was dichorionic diamniotic. So it was really a case of die pregnancy. And well, we had 2 previous ultrasound signs that were saying that it was a monodi. And well, of course, first ultrasound was done at 16 weeks, not between 8 and 13 weeks when it's easier to do the diagnosis. But well, this case, I bring this case, and I also like to discuss this kind of cases because, well, we have problems seeing these patients early on in pregnancy, and sometimes we have to know how to diagnose chorionicity after all. Would you like to say something else, Asma, or the colleague?
Yeah. I mean, I think what you showed me, which is, I mean, the lambda sign was so clear. And actually also the thickness of the endothelial membrane, I think for me, and I see loads of twins, it looked like thick. And so for me, I would have say it's dichroic twins. And I think also you did. But actually, interestingly, there's still many people said monocorionic, diamniotic. And then I think I'm just following the comments, and they say, well, if you have managed as monocorial amniotic, it would have been safer, and actually you probably have the same outcome. So but I think it's interesting. We had a discussion before about that in many countries, probably not all pregnancies have first trimester scan because they don't come to the healthcare professional and have an ultrasound scan that early. And therefore, I think because you see many of them for the first time in the second trimester, you said, well, I'm comfortable to actually say it's a dichorionic or monocorionic. But there's so many comments. I mean, there's very fantastic engagement from people commenting on your case. It's late.
And there's a very interesting comment here saying that when in doubt, I manage as monodi. No doubt about it. You have to manage as monodi. But well, Asma, I'm sure Asma would follow this one as di, and I also have seen so many of these cases that we follow as dichorionic. But well, in doubt, ever always follow as monodi. It's better for the patient. It's safer for sure.
Correct.
I would just like to show some complementary slides here, saying that, well, let me, now the chat is in front of my slides here. Let me close it. So here we see around 100 twin deliveries, pregnancies, and we have 100 cases per year. These patients don't have a problem to do ultrasounds. Most of them come with at least one in median, one ultrasound. Some of them arrive at our service after 4 ultrasounds. They usually arrive here at 14 weeks. So you can see that when I receive these patients, we are not able to do 11 to 14 week scans anymore because, well, there's some delays in our system. And what is striking is that we would like to see the ultrasound reports, and there's no information about chorionicity, or the information is incomplete in 45% of reports. This is really impressive. And for all cases that arrive here in my service, I don't agree with 20%, or there is no previous information, or I don't agree in 1 in 5 cases with the chorionicity definition. So there's a lot of disagreement, and I would like to show you how I try to define chorionicity in the second trimester. First thing, and I know that Professor Leung published a really nice 2 papers about pitfalls in defining chorionicity. But, of course, this is not going to apply for all cases, but we have rare cases where doubts might remain. But for the majority of cases, if we look for completely separate placentas, this would be the case of defining dichorionicity, and it happens, and this is the case in almost 50 to 60% of cases. If the placentas are similar, like this case that I presented, we are going to look for the fetal sexes, and if we have different genders, we might imply that this is dichorionic, and this happens in 55% of cases. If the placentas are the same, the sexes are similar, we can try to look for lambda sign. This is what we have done in this particular case, and this would be it would be possible to define chorionicity in almost 70% or nearly 70% of cases. And then if everything is similar and no lambda sign is seen, I look for placental width and separation of membranes. And usually when we see less than 1.5 millimeters, the hint here is Monochorionic placentas are really difficult, intertwin membranes, not placentas, are really difficult to see. You have to look for it. If you insonate them vertically, usually you don't see, you have to insonate them perpendicularly. And if they have around 1 millimeter, but less than 1.5 millimeter, probably they are more prone to be monochorionic diamniotic. If they are closer to 2 millimeters, they are probably dichorionic. So this is what we do. And of course, if you can't see any membrane or if the twins are conjoined, it's obviously mono-mono case, and there's no doubt about it. And the literature shows similar results. So last message for this first case, there is no twin pregnancies. Twin pregnancies are always monochorionic or dichorionic, and this has to be written in capital and red letters on your ultrasound report. I think this is the end of my first case, Asma. I think you are on mute.
Sorry, no, I was just saying this is fantastic. It's really nice. So please go ahead. You've got a few cases.
Nice. So next case, also from my service, Miss Zan, 23-year-old, first pregnancy, natural conception, planned pregnancy, nothing wrong in terms of previous pathologies, BMI 29, and she arrives at our hospital at 17 weeks and 3 days. See, another late referral with the diagnosis of a monochorionic diamniotic twin pregnancy. And this is, she also had 2 previous ultrasound before arriving at our service. First one was a dating ultrasound that has already defined monochorionic pregnancy, no definition about amnionicity at this point in time. And well, it may be difficult to see the membrane if it's really a monochorionic pregnancy. Then she had a first trimester scan where we only were able to check the nuchal translucencies that seemed to be normal, amniotic fluid, single placenta, monodi. Nothing was described about CRLs, but the patient referred that from this first trimester scan, there was already a difference in size of CRLs, but unfortunately, no pictures were attached in this case as well. And of course, she arrived at 17 weeks and we went for a scan to see if chorionicity was fine and everything was fine, especially because it was apparently a monodi pregnancy. And these are images of our first scan, and you can see here that was a striking difference in size of these babies. One estimated fetal weight in the 80th centile and the other one below the first centile. And you can see here abdominal circumferences, this one fetus A a little bit larger than fetus B, but well, apparently stomach images here for both ones, and apparently good amniotic fluid in both sex, and this was okay. Single placenta, T sign, so everything looked like it was okay, but we started looking for signs of, well, TTTS probably not, no polyoligohydramnios here, but we started looking for MCAs and umbilical artery Dopplers because it was a monodi pregnancy. And what can you say about these umbilical artery Dopplers here? I would like to open for discussion at this point. Let's see what there is in the chat.
To encourage people to intermittent absent endostolic flow. Someone said TAPS.
Absent and diastolic flow. So
Who's that? Who said TAPS? Who said TAPS?
There's a TAPS here, but well, I haven't presented the MCA. MCAs were fine at this point, okay?
Sona said also TAPS. I think selective fetal restriction.
Okay, so Yeah,
Sorry.
so as Asma has already explained it in her presentation, at this point, my diagnosis, can you see 40% difference in estimated fetal weights, or striking difference in fetal weights, one less than the 10th centile and more than 20 or 25% of differences. And here, yes, my impression was that majorly we have an absent end diastole here in the second baby. And at that point, my diagnosis was selective fetal growth restriction of the second fetus, Gratakos 2, because we have an absent end diastolic flow here. How would you manage these pregnancies? We are at 17 weeks, and now I would like to share to hear other opinions. Asma, please. How would you consult? Because this is different here in Brazil. You know that here in Brazil, we cannot offer pregnancy termination, selective pregnancy termination in cases like this. That we cannot offer cord occlusion or laser for this specific case. But well, maybe this would be in the toolbox in many other places in the world.
Ductus. I want to see the ductus venosus Doppler of the smaller baby.
At this point, the ductus was normal for both babies. I think I have not, but we are going to have some ductuses here in next slides.
Yeah. So I actually, honestly, having seen many of these pregnancies, and also we have a large multi-center study in the UK funded by the NHR, which is the funding national body for the UK. Actually, what I learned is the fact that the Dopplers, umbilical Doppler, at 17 weeks can change, and become positive, can become persistently absent or persistently reversed. So I think I would counsel a patient, I would definitely tell them about the risk of demise of the smaller baby and the potential consequences. And I would do mention sort of the options of management, but I would be comfortable with actually just monitoring for the time being, because I've looked after a lot of these cases and they did not die. So unless the ductus venosus was very like reverse A wave, some of them actually will continue, and sometimes umbilical Doppler does change.
Yeah. So at this point, the ductus for both babies were fine. I haven't put the images here, but we are going to see in the follow-up. As I told you, here in Brazil, we cannot offer selective termination. It wouldn't be probably the case at this gestational age, but this would not be an option. So we carried on following up this pregnancy, and this is 20. We have seen more times this patient between 17 and 21 weeks, but I brought you some highlights of ultrasounds during this pregnancy. And next one I would like to bring is the anatomy scan. And here you can see that the difference in fetal weight sizes, well, estimated fetal weights, were still striking. We tended to have amniotic fluid in the upper range for both fetuses. Not so TTTS was not worrying us at this point in time. Monodi pregnancy, you can see a very nice cervix. You can see that fluids were, as I told, okay. Abdominal circumference of the first one and umbilical artery Dopplers were fine. For the first baby, abdominal circumference stomach image was okay for this one, but we still had some mainly negative or absent end diastolic flow, but other things were observed for the second baby. So maybe an hypoplastic nasal bone, single umbilical artery, and well, what would you do at this point?
Okay, so I think, amniocentesis. Why would you do an amniocentesis, Zara? I think Zara's recommending laser and TTTS if the small dye is the bigger is not that. Ductus venosus. I think there is ductus venosus.
Yeah, the ductus venosus was still fine for both babies. Sorry for not putting the images here, but well, ductus was fine for both babies. But well, maybe someone is impressed by some signs that appear in the second baby here, and maybe a genetic discussion would be fine. Difference, estimated fetal weight difference was still high, 40%. I still thought it was a Grata-Cost-2 case. You can maybe say that probably there are some instances of reverse flow, but well, we had some signs that this second baby could have aneuploidy or other problems. We have talked about this with our patient, but the patient decided that she wouldn't like to investigate chromosomal or genetic anomalies because, well, in Brazil also it's not possible to terminate pregnancies because of this. He would accept the babies as they would come, and she decided to carry on following up. Doctors were fine at this point, and I think in my next slide I will start showing some ductus images here for this patient.
Go ahead. So now I know why she wanted amniocentesis. I understand.
So I carried on. So we carried on, following up the pregnancy. You can see here that umbilical artery always nice for the first baby. Ductus really nice for the first baby. Can you see here that, well, there is some interference from venous here, but there are apparently some reverse flow here and positive and negative, and the ductus is really different from the second to the first baby, but still positive. And still, at this point, I would say that it was not above 25th centile for the gestational age. And what would you say at this point? This patient really here is 23 weeks. What can we do for this patient at 23 weeks with these Doppler images?
I think some people are asking about your heart. Is the heart of the smaller baby normal or not?
No, normal hearts, morphology scan. Well, there was no space to put all the images, but despite of the hypoplastic nasal bone and single umbilical artery in fetus 2, fluids were fine, hearts, all other morphology aspects were normal.
Okay, fantastic. And someone's asking about the estimated fetal weight of twin, the smaller baby at 23 weeks.
Yeah. At this scan, I think, well, we had 1 week before the weights, so we haven't calculated fetal weight at this day, especially because below 24 weeks here in Brazil, there's no viability, so we were not worried at delivering the babies at this point. And everything was being counseled step by step. But at this point, what I would like to bring you is that we were a little bit more worried about being a Grata-Cost-3 type of selective fetal growth restriction, what brings not problems to the heart of the baby, but to my heart as a ultrasound maternal fetal medicine specialist, because we know that 20% of cases deaths could be unpredictable in this kind of cases, and this is how we started following this patient and counseling this patient. And I would like to bring the next ultrasound that was done around 26 weeks. And here you can have a look. Let me close you can see that amniotic fluids seemed to be okay. Fetus 1, nice umbilical flow and nice ductus. But can you see here, positive, absent, reverse waves. So now this is the best picture I think but we knew this from since 23 weeks. And at this point, the ductus was still positive, above 25th centile. Now our hearts became to be a little bit more worried because you now have viability. How would you follow these patients from this point on? Grata-Cost-3. And now new information. Do you remember that fetus 2 is the smaller one?
Yeah.
But instead of having oligo, we can see here that this baby has polyhydramnios. different from what we expect. How and she still was very firm in the decision of not investigating any further genetic problems.
And as a smaller baby, the bladder is not distended.
No, not distended. Both bladders always normal.
Yeah,
always.
so you're thinking about genetic cause.
Yeah.
Okay, so, well, people said they're going to wait, monitor with cervical length because the polyhydramnios. Someone said this heterokaryotype, heterokaryotypic monocorionic twin pregnancy, structure abnormalities like TOF, for example.
So really nice suggestions here. And well, and this patient was, we were, at this point, I was looking at morphology of this baby more and more, and well, there was nothing more that appeared strikingly except for the polyhydramnios, hypoplastic nasal bone, and single umbilical artery. It was not probably a case of one of the most common aneuploidies, maybe down, but well, first trimester and nuchal translucencies were fine as well. And well, this patient, we became a little bit more anxious after 28 weeks. So we admitted this patient, we hospitalized that patient because it was a Greta cost 3. And well, we were doing ultrasounds every day for this patient and cardiotocographies every day. And we were counseling this patient that the plan was to take this pregnancy closer to 32 weeks as possible, but well, every day something unexpected could happen and we could lose one or both babies. So she was obviously very worried, but comfortable with this discussion and with this decision. And well, the plan was to take two, closer to 32 as possible, but at 30 weeks and 1 day, we had a negative A wave on the ductus venosus, and we decided for a C-section. And you can see that one baby has more than a double of the weight at delivery, and well, you can see the striking difference in size. Upgrade scores were, well, okay. And after diagnosis, there was a diagnosis of esophageal stenosis of the second baby. That's why we had that polyhydramnios with fistula. So I reviewed all images, and the stomach was always fine in the second baby. It's really a difficult diagnosis in many cases, but babies are now 1 month, have now 1 month of age. Of course, there are problems related to prematurity, so ventilation support, but well, newborn A is clinically stable, and newborn B has been performed a surgery to resolve this esophageal stenosis, had a sepsis after surgery, but he is carrying on well, and he's under genetic investigation. Nothing major in the appearance or in the exams, only the esophageal stenosis and a mild hydronephrosis in this baby. So genetic investigation is going on, and well, I'll let you know what happens before. This is the last.
That's very nice. Yeah, really nice case. Really nice case, because it's I mean, we don't know the genetic diagnosis, but it's not like trisomy 21 or trisomy 18, and which you'd expect that you sort of have seen maybe heart abnormalities and so on. But there's definitely discordant anomaly, which might or might not be related to genetics. But really interesting case. But I mean, I don't know whether you have a slide about the messages from this case. The messages is that
this is the last one. Yeah.
Sometimes the patient is right. It's not always, it doesn't fit into the textbook. I think you manage to continue. I mean, this is a very severe early onset selective fetal constriction. You manage to get her to 30 weeks and have still 2 living babies. And to some extent, if there's no genetic abnormality, I mean, the 2 babies would have good outcome, reasonably good outcome. That's what she wanted, really. So really interesting case. Fantastic. Any
This is
other?
a nice and interesting case, and very nice discussions here in the chat box as well.
Yeah,
Unfortunately, I don't have the result of the karyotype yet, but well, it's coming. And this baby is under genetic investigation, so it's going to something will appear in time, I think. But unfortunately, it's a recent case, so I don't have the results yet.
But do you
But I
have the baby have other apart from the esophageal?
no, completely ectoscopically normal baby. CNS, heart investigation, everything at this point is okay, except for mild hydronephrosis bilateral. That was not, we were not able to see, it was not present at antenatal stage, only after delivery. And well, of course, the single umbilical artery and nothing else at this point. It's being investigated. Let's see what
Also,
happens.
esophageal atresia and the fistula is commonly associated with other abnormalities, whether with or without genetic cause. So you might find a genetic cause, but you might not find the genetic cause, you know.
But well, no signs, phenotypically, no signs of T21. So
yeah, no.
that would be a common thing to be investigated.
Fantastic. Shall we do one more case and then we discussion, because I think we're already more than 2 hours in the webinar, and I know you have more cases, but would definitely you're invited for the next webinar, Colorado, with this really interesting cases. But we'll do one more because we had a lot of questions earlier in the discussion, and I just that we also bring Stephanie to the discussion. So one more case.
No, this is also a nice case, but I would like to this is a TTS case, okay, but on a triplet pregnancy. I think we are going to I'm going to skip this case because there is another. Oh, I would like to bring this case, and I would like to hear to listen to your opinion here. So this is a bonus case, monocorionic, diamniotic. Everything was fine until 34 weeks and 3 days. So normal fluids, normal bladders, normal Dopplers, but 34 weeks and 3 days, no fetal interventions. We can see amniotic fluids. Well, there was no oligohydramnios. You can probably think, oh, maybe there's a polyhydramnios in one of the sacs here. And yes, in one of the babies, there was a polyhydramnios and the other one was normal. But, well, can you see here? MCAs starting to get this wide difference in MCAs, one approaching 1.5 multiples of median, the other one below the one multiple of the median. And well, some of these things strike me at this point. Can you see a difference in echogenicity in both placentas? A black and white placenta, an in young placenta here. And well, when I looked at the liver of the bigger baby, it also for me, it seemed to be like a starry sky liver. And maybe Stephanie would like to comment on this case. I think it was more interesting to bring this case because we have one person really interested in these kinds of cases here. And I would like also to ask for your opinion in the chat box here.
So Stephanie, please go ahead, unmute yourself. But the chat is full of tabs.
The chat has beaten me to the point. It's tabs because you can see with the echogenic placenta there's the starry sky liver. I mean, there's no hard images, but I'm pretty sure you might even have some cardiomegaly there. So yeah, I think maybe we are looking at a TAPS case.
Yeah, that was my feeling when I saw this case, and I went to my colleagues to discuss what to do next. And I would like to also to know and to ask in the chat, what would you do 34 weeks, 3 days? Probably TAPS case, difference in MCAs, these signs that we don't see every day, and spontaneous TAPS. What would you recommend?
And everybody, again, I don't know, they can see the chat, but everybody said deliver. So
So this is what we have recommended. So we induced this patient because fetuses were fine in terms of vitality in health. So this has already been presented by Asma in her presentation. At this point, we have a 0.8 ratio difference between moms, and this would probably be a stage 2 case at this point. And of course, we delivered here in our tertiary hospital, and you can see here the difference in colors. And this was also confirmed in hemoglobin and hematocrit after delivery. So it was really a nice spontaneous TAPS case. And we have, if you don't do MCAs, what's interestingly in this case, I saw the other signs before doing the MCAs, but well, this is not the case, and most frequently we are going to see difference in MCAs before seeing the 2D signs, or the other 2D signs of TAPS.
And I think that's really important to recognize, is that majority of cases will show some other signs of TAPS, but there is that 14% that won't show any signs at all other than the discordant MCA. So regardless of the staging system, it's the MCA is what you need to be doing.
Yeah.
And babies are fine and well.
And
Did you
there
do
was
hearing tests? Did they do the hearing tests?
Yeah, fine. Yeah.
Beautiful.
So we have this worry with the donor. Yeah, for sure. So this is something that we have to increase awareness more and more.
Yes.
fantastic.
And I congratulate TAP support for the brilliant job also.
Thank you.
I'm a fan.
Thank you. We're fans of yours as well. We're a fan of everyone. So if you're doing MCAs, we love you.
Well, that's also like a credit to all your advocacy work, Stephanie, and the TAP Support Foundation, and just like highlighting it, raising awareness is a condition that now I think people know about it and spot it just even from the science, even before doing the MCA Doppler, and in systems where the MCA Doppler is not routinely performed, as Conrado mentioned, sometimes you spot the liver, you spot the placenta appearance, and that sort of alerts you that maybe this is a TAPS here. There's one question about the hemoglobin. I don't know whether you have the levels of the hemoglobin or not.
Yeah, I had. Unfortunately, I didn't have time to put here in the slides. It came to my mind yesterday night, this case, and I put here, and I was not at the hospital, but they were strikingly different.
Yeah.
It was a TAPS case, confirmed or postnatally.
Lovely. Thank you very much. Really interesting cases. I know you have more, but I'm just conscious of the time. But definitely we will bring more the rest of the cases in a future webinar. So I think there have been some questions earlier that we will go back to them and just cover them in the next 15 minutes. Just one question that's relevant to that from Carlos, the number needed to treat for TAPS after a laser. And I don't know whether you have this answer, Conrado, but I think it's a really difficult question to answer because it depends what technique that you've done for the laser. Is it so whether you've done selective or you've done Solomon, because the risk of TAPS would be lower after the Solomon compared to the selective technique. So any comment, Conrado?
Well, this case we haven't done laser. Well, we have seen this after 34 weeks, but probably I have been in St. George's before. Well, it's well recognized that Solomon techniques usually tend to have lower cases of TAPS, of post-laser TAPS, because you are probably interrupting the blood of the small vessels between the babies. But well, if you do a selective and you are really looking for small vessels to coagulate, to photocoagulate in the laser, and I at least at the time I was there in St. George's, Solomon was not done for all cases. It was a selective approach, but looking for small vessels, they didn't have many post-TAPS, post-laser TAPS cases, and I think it depends on how on how you look for these small vessels when you're doing the laser. And Asma, please tell me how things are happening now in St. George's.
Yeah. I mean, I think I think Carlos, I know I sort of, I guess I'm monitoring the questions, and I think Carlos, you had a few questions and I think about, whether we should be routinely monitoring for TAPS or not. I think I can get sort of the hint of the questions, because the follow-up question was that how many ultrasound scans you need to perform to diagnose the case of spontaneous TAPS or TAPS. And it's not really that question, is it? Because you're already monitoring them every 2 weeks. It's just the fact that you will take you, I don't know, a couple of minutes or a few minutes to do the MCA Doppler for both babies. So it's not like you're not doing a whole additional scan. But that's another sort of debate, whether we should be monitoring for it or not. But I think that's probably what Carlos probably were asking about. I don't know, Professor Lung, if you are still with us, I know you're away. So if you're not with us, we're not able to sort of answer the questions, you are fantastic. I'm just gonna bring some questions from earlier regarding your talk. People really appreciate, because obviously it is quite complex topic, especially with zygosity versus chorionicity. And I think I'm just bringing, there's so many questions and comments. People have been really, really interactive, I think, especially with the cases and responding it. But for Professor Lung, very interesting. So with the SNP, we can predict dizygotic or monozygotic twin. How can SNP and NIBS can be used in a triplet pregnancy? I suppose it can only accommodate maximum 3 genetic profiles, mother and 2 fetuses. Thanks. So I think maybe just to comment on the SNP technique for self-regaining.
Right. Now,
can you hear? We can't hear you. We can't hear you, I think. Are you on mute? I don't think you are on mute, but we can't hear you. Okay, maybe it's just the connection is not great, maybe. So just Professor, like I think he's traveling, so that's why probably the connections might not be good. But while he's maybe trying to sort out the technical issues, I think might just take a question from earlier, just like, as I said, we will finish definitely in the next 10 minutes, because I think it's not healthy to be in front of the computer for that long. And Stephanie, please.
I will. I was just actually going to add something. I know that there was a few questions about the frequency of TAPS monitoring and when to call a diagnosis. One of the things that we counsel patients who have come in and had one bad MCA with.
Right. Many companies are reluctant to.
Yeah, no, okay, sorry, I'll just really finish. Is we just say one bad MCA just means try again in a couple of days, because TAPS is about establishing a pattern. So it's over a period of time that you look for those discordant MCAs, and if they're still apart or they're still drifting apart, that's when a TAPS diagnosis is usually made. But you can't make a call on one reading unless, of course, you see those other signs of TAPS, and then is just increase the frequency of monitoring and keep an eye on it, is how we tell patients to react.
Fantastic. Lovely. Thank you very much. Really, really useful comment. Professor Lung, are you able to?
Can you pardon? What is the questions?
Yes, about the SNP technique for determining the zygosity, and also particularly in the context of a triple pregnancy.
Right. Now, so for triplet, it could be monozygotic, 1 split into 3, or dizygotic, 2, one of them split into 2, right? So in this situation, NIPT is still applicable, right? As long as you have adequate fetal fractions, right? So it's just like in twin pregnancy, so you can still do it, right? Now, in case it is trizygotic, right, then of course it is more demanding, it's more difficult to do it, and usually most companies will not accept it, right? So what you need to do is, one, take out the history of conception, whether it's lateral, IVF, how many embryos was transferred back, and also do ultrasound to see whether it is MCTA or DCTA and so on. Now, if it is MCTA or DCTA, I think you can still do NIPS as in singleton or twin pregnancies. If it is TCTA, which is probably due to embryo transfer of 3 embryos, right? Then probably it's difficult to do it. But if you have a clear history that is IVF pregnancies, you have 2 embryos transfer, and then you find out to be TCTA, it's still possible that it is a dicyclotic, and then you may be able to do it, right? But you need to discuss with the commercial company who offer the test.
Okay, fantastic. I mean, it's an area where I think still the evidence is building up, is it? So I think as more and more people are reporting, and certainly, until recently or until now, many companies will not offer cell-free DNA in a triplet pregnancy. And having said that, the data is on the performance of cell-free DNA for trisomy 21 in triplet pregnancies is accumulating. And certainly we put the data together and it appears to be promising for trisomy 21 with maybe a higher false positive rate. But I guess it's, the data is accumulating, so hopefully we'll be able to understand more. But it's an area with still limited evidence. But thank you very much. There was earlier comments about sort of the guideline and the triplet or higher order pregnancy, and it is, of course, we should have one. I think it would have been impossible to include all of it in one guideline because it's already a huge amount of work. And I'm hoping that maybe you will have a guideline on triplet pregnancy. I think that will be really useful. But we have to appreciate that obviously there's limited evidence because of the number of pregnancies that available in the literature. But I'm hoping that this is work in progress. Okay, concluding remarks from Stephanie before this close.
Just always appreciate being invited along and being able to give the patient perspective. I did want to also bring up that together with asthma, I have actually written a patient guide to the ISOUG guidelines. I will drop that link into the chat. This is really developed in line to give you something to patients to help them understand the process that goes behind not only creating the guidelines, but why the guidelines exist. And we have worked together to bring this to everyone. It's simplified language, but it's not oversimplified. It still has the feel of the guidelines. It's structured the same way as the guidelines, and it's available for download on the TAP support website. And we are very happy that I was very happy to be able to do this because the guideline is really such a strong guideline. But yes, I'll drop that into the comments and it's ready for anyone to download and look through, but it's there.
Fantastic. Okay, and just maybe before any other comments or suggestion, I mean, I flicked through the comments and I think we addressed most of them. I think in terms of the guideline itself, I think I appreciate that it's difficult to cover every single thing in twin pregnancy in a guideline was obviously focusing on the role of ultrasound. And as I mentioned, hopefully I'm hoping that we might have an ISOUG guideline on triplet pregnancy to address the various aspects of monitoring and management of triplet pregnancies. But on this note, I would say huge thanks to all the speakers and Stephanie for joining us today. I really enjoyed the webinar. I think many people did. I think it's just seeing the comments. I think it was very interactive, and I think a lot of people sort of engaged with the cases and sort of providing input about what they think that should be the next steps in the management. So that was wonderful. And just again to thank you for the Samsung for sponsoring. Thank you for all the delegates for being super interactive and engaged and still staying with us after 2 hours on a webinar in front of the computer. Thank you very much. And again, huge thanks to my team who work really hard behind the scenes to make sure that these webinars are successful. So just to remind you, these webinars are recorded. They're available free on the Jaffic Health Foundation website. And also just to remind you, please fill the feedback because I'd love to hear from you, whether positive or negative comments or any suggestions for future webinars. And I really hope that you enjoy the rest of the weekend. Thank you very much, and I look forward to seeing you in another webinar.